So if we're going to start first with a presentation from Kristen Campbell. So as you've heard, she's the program lead from Child and Family Nursing Orientation and Preceptorship of St. Elizabeth in Toronto and Markham area. And you're going to provide us a presentation of the work of your team with community home care services with complex care population.
Right. Thanks, Natalie. Hi. Lisa, can you see my screen?
Yeah. Can everybody see Kristen's screen? Everybody logged in on the...
Yeah. Okay. Great. Okay, so we'll get started. And I'm also joined here today by Veronica Gazarian. She introduced herself earlier. She is our Program Development Leader for Occupational Therapy for the Schoolhouse Support Services and Pediatric Program. So we're hopefully going to give you a sense of the work that we do. We don't necessarily have a formal quote-unquote complex care program. However, we do most certainly provide service to these children. So we just wanted to first of all start by telling you a little bit about who we are, for those of you who may or may not be aware. So St. Elizabeth was founded in 1908 with an original staff of 4 visiting nurses. We have continued to grow over all these years. Nationally, we have a team of more than 7,000 staff, and we deliver over 6 million healthcare visits annually. We also have a very well-established national health service support program for First Nations, Inuit, and Métis communities. We are a not-for-profit and charitable organization. Our vision is to honor the human face of healthcare. St. Elizabeth spent, the first 100 years focused on what we want to achieve within the organization, and now we're looking to move that beyond our walls and how we can also, help to influence the healthcare system. So our Child and Family Program, the objectives mandate of our program, is the provision of pediatric care with a number of different focuses. Those include health maintenance, providing care allowing children to remain independent and at home, restoring to previous health states, and palliative care to children and their families from birth to 18 years of age. Specific care within these focus includes infusion therapy, wound care, complex care, maternal newborn care, chemotherapy, respite, and respiratory care, just to name some of the things that we do. Our services are provided by an interdisciplinary team that includes nursing, personal support, and rehabilitation therapists. We have physiotherapy, occupational therapy, speech-language pathology, dietitians, and social workers. Our therapeutic program includes client health improvement interventions with a focus on skills development and education for clients, families, and caregivers. The goals of our program, oh sorry, yeah, right, Veronica, I'm sorry, we're going to turn it over.
Yeah, that's okay. Nope, I was
getting so excited about our presentation.
Okay, so it's Veronica Gazarian now. I'm going to take over for a little bit. The Child and Family Program goals. So we deliver care focused toward enabling and maximizing independence in the environment best suited to the child's and family's needs. Often this is at home or at school. And we empower families with knowledge and skills to be as independent as possible in meeting the healthcare needs of their children. The program components. So the spectrum of child and family care, it does include maternal newborn care, as well as acute and chronic pediatric care from birth to 18 years of age. Services are offered via visits or shifts within the home or school. Patient type and inclusion criteria. So this is not exclusive. This is just to sort of gain a picture of who we do service, and it does include more than what's mentioned here. Typically, they may have one or more chronic clinical conditions, either diagnosed or unknown, that are severe and or associated with medical fragility. They may have functional limitations that are typically severe and may require assistance from technology such as tracheostomy tube, ventilator, feeding tube, or a wheelchair. The organizational structure for complex care nursing. This service offers shifts typically between 4 and 12 hours to children with complex healthcare needs resulting from a dependency on technology for a fragile status. Service includes supportive interventions to promote normal growth and development and adjustment, monitoring and management of complex conditions, respite, and teaching. Our school support nursing service is designed to meet the needs of children with complex healthcare problems within the school environment. These needs may be met on an individual or group basis depending on the child and the type of school and the child's needs, or the type of school the child attends. They're focused on ensuring that the child's healthcare needs are met within the school setting with minimal intrusion in school and socially related activities. Our rehab services provide in-home, in-school, and community-based services in physiotherapy, occupational therapy, and speech-language pathology. We also have registered dietitians and social workers. Clients include those discharged from hospital with acute, chronic, and complex care needs that may have disorders involving cognition, function, movement, and communication resulting from cognition and developmental disorders, illness, and accidents. Our services are also provided to children with chronic medical conditions, palliative care needs, and acquired brain injuries. Rehab services for complex care. Our professionals work in collaboration with a team, often liaising with parents, always liaising with parents, caregivers, the school team, and other professionals. Our visits are provided in the home, school, or community. We provide comprehensive assessment and treatment planning. We strive to respect the schedule of the family and provide joint visits which enable timely and relevant care plan modifications. And our focus is on skill development, education, training, equipment prescription, and capacity building for families and care teams. Some of the advantages of our complex care rehab services include that we have therapists who have relevant and current skill sets for working with children with complex needs. Our community therapists working with children with complex needs are trained to address very unique situations in unique circumstances. And the therapists and other team workers work very collaboratively together. So it's a very comprehensive program.
Okay, so we also have personal support services that also work with our complex children, providing support to both the child and the family. Services are offered within a range of settings, and personal support workers work closely with other members of the interdisciplinary team. They assist with feeding, bathing, and supervision of play and activities as requested by the parent guardian and as directed by a regulated healthcare professional. We assume the role of caregiver to provide temporary emotional and physical relief to the primary caregiver. All our supportive care workers are prepared at the PSW level, and we do provide ongoing education for them as well. So we just wanted to talk a bit about, the funding model, which many of you might be familiar with, but the home care services are provincially funded. And so that is driven by each province. And so these are just some examples. So for British Columbia, the regional health authorities, Ontario through the community care access centers and fee-for-service, Quebec government health and services through the CLSCs. In Ontario specifically, it is a managed competition environment. And so depending on, the child's access to service or how they meet or how the criteria they've met for service, that will depend on those assessments that are completed by the community care access centers. as well. Across the country where there's a shortfall, we do provide fee-for-service as well as other sources of funding. For example, those families who do not qualify or want additional service. For example, like many other organizations, we do provide respite care where families cannot afford with monies raised by our foundation. So just looking at our evaluation framework for our program, our vision is around looking at our infrastructure, practice, leadership excellence, and our people. And hopefully our outcome would be quality. Do we have highly satisfied clients, best clinical outcomes, care that is safe, delivered with consideration to efficiency? So I just wanted to provide you some examples of some of the data points we are looking at for our families. Continuity, percentage of clients and our caregivers report overall satisfaction with care. Percentage of clients and our caregivers report satisfaction having been involved in the development of their plan of care. We also look at risk occurrences that occur in our pediatric population. Also, percentage of clients that report staff wash their hands before care. Percentage of nurses who have specialty training. We also look at that at St. Elizabeth for get a sense of, what training our staff have at various sites to be able to support this population. So, lastly, what's next? These are just some thoughts that Veronica and I had around opportunities for collaboration with a broader scope of children's treatment centers and children's hospitals, acknowledgement and sharing of information regarding the unique circumstances of children with complex needs in rural and suburban areas, and we always want to use data to further inform improvement work, especially internally when we work with these children and families. And that is what we have for you today.
Thank you. I wonder now if we could go around with if there's anybody who has questions.
I wouldn't mind starting off, Natalie, if that's okay. It's Hema Patel calling from Montreal.
Hi, Emma.
Hi. Thank you very much. It's really been a pleasure to hear about St. Elizabeth. I've been hearing the name for a long time, but I certainly didn't know sort of the details of your program, so it's been very interesting for me to hear. I just following along with PowerPoint, what role do pediatricians or physicians have in this model of care?
Well, Veronica, you could speak to this as well, but I think that depends on the, well, Veronica, go ahead.
Well, I'm actually somebody who is quite involved with family and children with complex needs, and our teams include the pediatricians both at the hospital and in the city, in the community, and we have regular what we call pediatric rounds that we attend. Usually those are the first day of every month. And so sometimes the pediatricians are able to attend, and when they're not, we definitely communicate with them either before or immediately following, sometimes during the meeting by teleconference. Clients' families have been encouraged to attend, and whenever possible, we try to make that possible for them, even if it means respite or PSW overlap. But certainly, much of what we do depends on our communication with the pediatrician. And so we're very involved. They're an integral part of our team.
And sort of following from that, I'm really interested to know, how does the care documentation follow the child through these different places that they are in, the home, perhaps the community office, and then the hospital? Oh, how is the record keeping? How is that structured?
So we have something called the pediatric chart in the home, so quote-unquote chart in the home. Okay. And it's a binder that is divided up into sections, and it includes all of the information about the providers that the client has, both in hospital and in the home, and as well with the Children's Treatment Center if they attend there as well. And so that binder stays with the client, and they bring it to their appointments. And we can all document in that. There's a space for all of the disciplines. And it's very useful. It includes spots for nursing, for example, for physio, for OT, for the pediatrician, for any of the specialists, and then there are folders for extra information that is relevant for us to share with each other.
And that's a paper template?
Yes.
Is it something that you'd be willing to share with CAPC?
Certainly. I mean, it's an initiative between several organizations, and so I think, you know, it could only be of benefit if we can share that. So I'd be happy to do that.
Have you thought about taking it electronic?
We've had a lot of discussion about that. There are some points to that make it a little difficult. We like the client.
Yeah.
The client has to have access to the information, and not all of the clients that we service have the same level of access when it goes electronic.
Mm-hmm. Thank you.
Yeah. You're welcome.
Veronica and Kristen, it's Elaine. Just a quick question building on what Hema just asked. At the beginning of the presentation, you talked about your services in home and school and the community, etc. So this pediatric chart in the home, is that something then that, you know, your community, the services you're providing in community or in the school, I'm particularly interested there, for example, is taking it to a bit of an extreme. Is that chart then accessible to the provider in the school for that particular child and family?
That's an excellent question, and I find that for the population we're talking about today, it is acceptable at the school. But for some of us in rehab, for example, we actually have two different systems that we have to be accountable for in the school. And so there's the medical chart, but then we also have Ministry of Education documents that we have to complete. And so we have forms that are triplicates that we write on, and so a copy comes into my chart, and then a copy goes to the school, and a copy goes into the chart in the home, which then is available for the parent.
Mm-hmm.
Does that answer your question?
It does. It does. So there is that continuity, if you will.
Yeah.
Yeah.
And the triplicate, it's called a visit note, and there's other forms of that as well. There's, you know, we have another form that we use for communicating with pediatricians when we know, for example, that a parent is going to an appointment. And if we haven't been able to share information in person, then we have a note that is a duplicate copy. So we write on it, we keep a copy, and then the parent has one to bring with them to the pediatrician in the chart.
Okay.
May I ask another question? It's Hema. Unless somebody else should go first, I shouldn't take all the questions at a time.
Go ahead, Emma.
Thank you. Am I right in understanding then that the CCAC would contract out to St. Elizabeth to provide a specific care? Is that the way that is that structurally how it works?
Yes,
yeah.
In Ontario, that is correct.
Okay, and so then are you getting any, one problem we have here in Quebec is that our CLSCs have certain documentation they want to do in the home, but they feel that they own that documentation. So it isn't something that's shared with parents. So let's say you have a child that has complex care needs at home, then the nurse that might be there from the CLSC would be documenting for her work responsibility, but the parents were even instructed not to look at it. So we've been having conflict between who owns the document and who's allowed to read it, who's allowed to contribute to it. And I take it you do not have that mess.
I don't know if you want to comment on that, Kristen, from a nursing perspective, but I have comments from the rehab perspective.
Go ahead, Veronica.
Okay, so I certainly understand what the dilemma is, because over the years that has happened in our region anyway, and we've addressed it a few different ways. So the first thing to consider is that we're all governed by our colleges that dictate really what we have to document. And I know that it always works and has in all of the regions that I've worked in when we collaborate with the children's hospitals and the community care access centers in Ontario to have forms that contain the relevant information as required that can be left with the client. Certainly we have our own chart where we document our progress notes, but all of the forms that are intended for purposes of sharing are available to be seen by anyone that's involved in care because they do go into the chart. They go into the chart in the home. And so we've collaborated often interagency and with the hospital and the CCAC. So for example, locally we have paperwork related to our complex feeding team with McMaster, and I'm sure those on the line from McMaster, are aware that, they have some therapists who are quite involved with children with aspiration issues and that sort of thing, and we've worked with them to develop paperwork that includes the necessary information but can also be read and, understood by parents. Does that answer your question?
It does. So you actually have a chart in the home and you have a chart at St. Elizabeth.
Correct.
Got it. Thank you.
Yep.
It's Natalie. I also have a question about the continuity. One of the challenges that these children spend sometimes in the hospital, at times for quite a long time. And the challenge for the parents when they go back home is they usually want the same workers as they had prior to hospitalization because they know their child. And I'd like to hear from you. Is it something that you've been able to manage? And when you do, how do you overcome this time period while they're being hospitalized?
Kristen, do you want to speak to that one?
Sure. I totally hear you, Natalie. We do hear it at our end all the time, and it's something that we try to maintain continuity as best possible, and it's something that we're working towards every day. It's something we deal with every day, and we do hear feedback from families that when they have a particular, I can speak to nursing specifically, when they have a specific nurse, as you said, knows their child and whatnot, we do try to respect that as much as possible, but it does run into challenges even when nurses go on vacation or whatnot. It's really something that we have to try to manage.
Okay.
And from a rehab perspective, we actually follow clients both at home and at school, and we make every effort to ensure that they have the same therapist at home as they do in school. And it does involve quite a bit of juggling sometimes, but we do recognize that that's important for families, and so we make every effort to have that happen. And I would say in the rehab world, it happens most of the time. A very high percentage of the time they will have the same therapist at home as they do in school.
And Natalie, and that's why I mentioned that as sort of one of the first bullet points in our evaluation criteria that we look at. We are always looking at that measure of satisfaction in our families, and to try to, it sort of speaks to what we're talking about here around continuity.
Mm-hmm. Any other questions?
One more very quick from Emma. What would be the most complex type of patient that you would have in your program? I'm just wondering about the type of medical complexity. Would you have kids with home peritoneal dialysis?
In some areas we do.
Home TPN?
Yes.
Yeah.
And home tracheostomy ventilation?
Oh, very much so, yes. Many.
Yes. So would those three groups be the most complex, or would you have children even more complex than that in the home?
I would say for rehab that we could have children who are more complex than that in the home.
Yeah. I would agree.
Could you think of an example? I just trying to get a flavor for what kind, like how far the care is in the home setting. Is there like a type of patient that you can think of?
Sometimes we have children. Well, we see infants as well, right? And so we have children who are, discharged home from the critical care unit after their rehab portion at the hospital, and we're the first responding team as rehab providers to go in with the nurse. And if I'm thinking of a school-age child, we have children with all types of medical conditions, but, one that might be a good example would be a child with Batten's disease who has a trach, is ventilated. Their care can vary from day to day. Sometimes they cannot attend school, sometimes they can, and when they do, it's quite involved for them to be able to go to school.
So very fragile patients also.
Yes.
Thank you.
Okay. One more chance for another question. Okay, so thank you very much, Kristen and Veronica, for this wonderful presentation. And if there's any further questions, I'm sure you could email them either to Lisa, Kristen, or myself, and we can keep you informed of those further questions as they arise.
Yeah, most definitely. We're open to any emails or questions. That would be fine.
Okay.
Yep.